Welcome to EuroPCR 2024. I'm Dan Blackman, an interventional cardiologist from Leeds in the UK, and I'm here with my colleague Professor Phil Maccarthy from King's in the UK, and we're going to talk today about the key considerations in patients who are having TAVI, who have a long life expectancy. So Phil, the implication of this discussion is that we're treating younger patients. Can you tell us where we are in 2024 in terms of the age of patients receiving TAVI today?
Yeah, we're witnessing quite an interesting evolution. What's happened in Europe and the USA is that the age of the patient, which is now around 80 to 82, hasn't gone down that much, but the surgical risk has. So we've gone from treating high-risk elderly patients to high and lower risk elderly patients. But what I think we're on the cusp of now is seeing this age come right down. And we're witnessing that in the USA, where many patients between the age of 65 and 80, as per the American guidelines, are opting to have TAVI, and their physicians are opting to treat them with TAVI. So my prediction is this age is going to come down quite sharply now in the coming years.
And we've seen that in the US even pushing below 65, right? Recent data from New England, from California, showing over 50% of patients under the age of 65 having TAVI rather than surgical AVR. So patients maybe with 20 plus year life expectancies.
Yeah, exactly. And I think that we're going to witness the reflection of that in Europe and the rest of the world in the coming years. There's no doubt that this is going to be the trend.
So Phil, if we're treating these patients with 20-year life expectancies, I guess the first key question is, how long is the TAVI valve going to last? Can you tell us what data we've got about long-term TAVI durability in 2024 that maybe reassure us that we're doing the right thing into moving into these younger age groups?
Yeah, so after the initial concerns about TAVI durability some years ago, actually all of the data is really reassuring, and I'm repeatedly reassured by durability data. We've got extremely good durability data out to 5 years with several TAVI devices, and in fact there is now 10-year data coming out and being published, and I think we're going to witness more 10-year data coming out with first-TAVI and Partner 3 in the near future. So there's also a wealth of registry data which really does suggest that the TAVI durability is very robust, and I would say at least as robust and at least as good as the surgical bioprosthesis data.
Good, yeah, no, I agree. I mean, we've seen Notion present 10-year data showing at least and maybe superior durability.
Yeah, it's fantastic because the haemodynamics are better. So we're not surprised, but scientifically that makes sense.
Yeah, we start off with a bigger valve area. Yeah. It should take longer for it to get to a small valve area that needs retreatment. So that's reassuring. So I guess for our viewers today, the other thing we've got to think about when we treat a patient with long life expectancy is how does it change the index procedure? So how can we optimize the first TAVI procedure, planning for long life expectancy and thinking about a 20-year plus time horizon? What are the key issues in your mind when you're taking on a patient with a long life expectancy?
Yeah, it's a really good point, and I think it's taken us a while to realise how important the first TAVI is. TAVI's been around for 15 or 20 years, so I'm surprised it's taken us so long to concentrate on this issue, but now the declining age forces this into the limelight. I think it's really important to think about the second intervention when you're doing the first. It seems a bit bizarre if you're treating a 65 or 68-year-old, but it's absolutely important. And I think the issues are the haemodynamics. So you have to achieve excellent haemodynamics with your first TAVI valve, and that means a low gradient, and it means no PVL if you can possibly achieve that. You've also got to think about coronary access. We all worry about coronary access 10 years after the TAVI when our patients develop coronary disease, and coronary access is vital, I think. And this brings into light the commissural alignment. If you can somehow achieve commissural alignment, you will access the coronaries with more ease. And also there's some suggestion that maybe that will impact on durability as well. And then there is the placement of the valve, and I think where you're placing the valve is a really difficult issue, because if you place it too high you'll limit coronary access, but if you place it too low then you'll risk a high incidence of permanent pacemaker requirement. So there is an issue about where to place the valve, the sizing of the valve, and also the device type. All of these issues are important.
Yeah, and there's a lot we've got to learn about that, right? But really, I think, as you said, a key thing in that first procedure is when you're analysing the CT, we're used to thinking about analysing the CT to plan the first procedure.
Yeah.
But we've got to start thinking about how the second procedure is going to happen.
Exactly.
And putting that valve in a way that, as you say, preserves coronary access, but also enables us to be able to do a redo TAVI without causing even coronary obstruction or sinus sequestration.
Yeah.
Phil, I mean, it's been a great discussion. I think there's a lot to learn about this. We can conclude by saying that we're moving into patients with longer life expectancies.
Definitely.
We have to expect that these patients may outlive their valve. So we've got a plan to optimize the durability of the first valve, but also to enable retreatment by redo TAVI if and when required in the longer term.
Absolutely right.
So Phil, thanks for the discussion today. I think it's been a good one. It's a key topic. We're going to learn more over the years to come. And I hope our viewers have learned something today.
Thanks, Dan.